Excellent. Good afternoon, ladies and gentlemen. My name is Amy Rutkowske.
And I'm Laira Roth.
And together we bring more than 15 years of experience in the healthcare field to our company, MedConnect. We are current students in the Milken Institute School of Public Health here at the George Washington University, and we are finishing our Master's in Healthcare Administration. MedConnect is a telemedicine platform that provides a new channel of communication between health service delivery organization patients and their providers. We are a business-to-business company, which means that we interact with the health service delivery organization to provide this value-added service for their patient population.
So I'm sure some of you have experienced this scenario in the past. You wake up with a bad sore throat, or maybe you feel another sinus infection coming on, and the last thing you want to do is call up your doctor's office, schedule an appointment, then take time away from work or other commitments to go in and see a clinician. Well, you are one of millions of Americans that delay or avoid seeking health care because of the inconvenience and the hassle. We all know that the healthcare system is very complex, and there are many pain points that exist in the system for three primary groups: health service delivery organizations, clinicians, and patients. And these are the three customer segments of our company. Health service delivery organizations, or what we call HSDOs, include hospitals and primary care clinics and other healthcare facilities. These are our primary customer and the purchaser of MedConnect. So we know that the Affordable Care Act right now is changing the way that these institutions do business. They have to do more with less. They have to reduce costs, they want to keep their patients out of the emergency room, and they want to be improving patient satisfaction scores. Clinicians include doctors, nurse practitioners, registered nurses, and physician assistants that work within the health service delivery organization. And the pain points that this group experiences is that they are having to see more patients, and they don't have a lot of resources or time to do it. And also, they're being held accountable for the health outcomes of the patients that they're serving. And then finally, as patients, we all know what those pain points are. We struggle with the inconvenience and hassle of trying to get connected to a clinician in what we believe is a timely fashion. Also, I would argue that many healthcare providers are not necessarily using technology that we use in our everyday lives to access other services on a regular basis. So here's an example. Let's say you're Circa Health, a primary care practice serving 25,000 patients. Right now, if one of your patients has a sinus infection, they have three options for accessing care. One, they can go through the process of calling up your office and scheduling an appointment and then waiting to see one of your clinicians. Two, they can go down the road to the local urgent care clinic, which is not only an inconvenience to them, but that's taking revenue away from your business. Or three, they might delay and hope that their symptoms get better, but if they don't, chances are they might end up in the emergency room, which is not only an overutilization of resources, but it is incredibly costly to the system.
Now there's a fourth solution, MedConnect. MedConnect is the aspirin for all the pain of a patient who wants to see a clinician immediately. Here's how it works. Circa Health partners with MedConnect to provide this telemedicine application to their patient population. The patient downloads the app, logs in, verifies some information, tells us where it hurts and how badly they're feeling. Then they see a list of your clinicians at Circa Health. They can read the patient reviews, they can read the doctor's full profile, and they can select their clinician from the list of available people. Most importantly, they choose and they know when this video consultation will take place. Your patient selects Dr. Moeller and 8 minutes later engages in a private, personal video health consultation to address their needs. After the video chat, your patient receives push notifications with information on where to pick up their electronically prescribed medications, any follow-up instructions, and educational materials Dr. Moeller wanted them to have. This is healthcare at your fingertips through an institution that you already know and trust. And the market is ripe and ready for MedConnect. And we know this because in the 180 days that Amy and I have been developing this company, we have spoken with 60 individuals that represent our three customer segments.
We've had conversation with 10 key decision makers at health service delivery organizations in this area, including Inova, Virginia Hospital Center, and even GW Hospital. From these conversations, we know that these institutions want to be able to maximize their revenue. They want technology that puts them at a competitive advantage in the marketplace. They want to keep their patients out of the ER, and they want to improve their patient satisfaction scores, mainly because there are now regulations that hold them accountable to that. These individuals include chief medical officers, chief technology officers, and other C-suite individuals. We've spoken with 20 clinicians that range in both profession type and specialty. And from these conversations, the clinicians are telling us that they want to be able to deliver efficient, effective care to their patients. They want to be able to maximize their resources, and they want technology that seamlessly integrates with their electronic health records and that's easy to use. And then finally, we have spoken with 30 potential patient users of MedConnect, ranging in age from 18 to 65. And these individuals want shorter wait times, they want flexibility in scheduling their appointments, they want easy, on-demand access to care, and they want to be able to interact with a clinician that they know and trust.
The telemedicine market is growing exponentially. Forbes estimates it will continue to grow at a 50% rate annually into the foreseeable future, putting it as a $2 billion industry by 2018 with well over 1 million patient users. Right now, there are 317 million Americans, 276 of whom have health insurance. And at the moment, less than 1% are using telemedicine services. We've identified 4 major competitors in the telemedicine marketplace. They are Teladoc, VC, MD Live, and Amwell. The difference between MedConnect and our comparable competitors is that our model is unique in 3 ways. Number 1, we partner directly with health service delivery organizations, which means that we are tapping into their existing patient population to add this as an added service for their patients. Number 2, rather than contracting out for external clinicians, we are going to be using the clinicians that are already working within that health service delivery organization, which means that they're operating already under the clinical and legal protocols of that institution. And then finally, we're developing a MedConnect platform to integrate with the top 2 EHR vendors out there, Cerner and Epic. The barriers to entry are this. We know that in this field, these types of institutions, they do take a while to adopt and implement new technologies. However, someone is going to be getting there, and we want to be the first movers in this space. We will be establishing 5 to 7-year agreements with our client HSDOs. We will be applying for a provisional patent of the mobile application for MedConnect, and the back-end hooks that make it interoperable with Epic and Cerner will be trade secrets in the industry. Amy and I are already getting out there. We're having these conversations, we're promoting MedConnect, and we know that those are valuable components. We will continue to advertise this through healthcare conferences, industry-specific publications, and social media. But we need your help in connecting with key decision makers in the health service delivery institutions in this area. We know that that human-to-human connection is a valuable component of our marketing plan. All right. So these are just a few of the things that people are already saying about the MedConnect model. Just kidding.
Before we get there.
Before I get there, how we make money is a volume-based subscription model. My apologies. Let's take an example. That 7-physician practice with 10,000 patients, if we assume a 15% market penetration or patient engagement rate, then we know we'll have 1,500 MedConnect users. 1,500 users at an annual subscription rate of $125 per person per patient means that physician practice will pay us $187,000. Our financial projections for the next 5 years are to be cash positive in our 3rd year with an initial investment of $1.25 million. Additionally, in our 5th year, we'll gross more than $13 million in sales revenue, have a 51% operating margin, and that's based on having 65 customers at an average run rate of 15 new clients per year.
As co-founders of MedConnect, Amy and I bring 15 years of experience to the healthcare field. Amy is an Army Medical Corps officer specializing in health information technology, lean implementation, and risk management. And I'm a project manager in this space with expertise in healthcare policy, clinical quality improvement, and population health management. Together, we form a formidable team, and we complement each other in both skill and expertise. But we acknowledge that we are lacking in the technology sector. That is why we are actively seeking a third partner, a software engineer that can serve as our chief technology officer to help round out our team in both knowledge and skill. We are fortunate to have a strong board of advisors. Sam Hanna and Jose Laguna bring entrepreneurial and technological experience to our venture. As serial entrepreneurs themselves, they offer invaluable startup and financial guidance. Christy Rudolph brings over 20 years of clinical experience as an ICU nurse and has been involved in MedConnect since its inception. And Dr. John Colkin is a nationally recognized orthopedic surgeon with venture capital and entrepreneurial experience himself.
These are the things people are saying about MedConnect already. They like our model, it's smart, and it saves money. We have endorsements from health service delivery organizations, clinicians, and prospective patients. Healthcare reform is changing the way we deliver care in America, and telemedicine is integral to the future of this space.
With your support and with the first place prize, we will complete our minimum viable product, we will conduct beta testing, and we will find a chief technology officer. MedConnect will fundamentally change the way that we access healthcare, and we want to bring this into health service delivery organizations across the country. So with your support,
together we will mainstream the modern house call.
Thank you.
Yes, ma'am.
So I don't understand the flow of payments very well, and I was hoping you could bring it down to your very first client. So is it a company like George Washington Hospital? Would that be, as an example?
That's a big example, yes, ma'am.
Okay.
We were thinking our first client would be a smaller one.
Okay, so smaller one. So pick a smaller one. Is it an HMO? Is it a hospital? What kind of?
It's actually a physician practice. So that physician practice that has 10,000 patients per year.
Okay.
And we would contract with them.
Okay, so they would pay you a fixed amount for all of their patients.
Volume-based.
Okay, volume-based. And the doctors would get paid how exactly? Just talk me through the flow of payments.
Sure, absolutely. This makes a lot of sense whether patients are in a fee-for-service model or whether they're in a shared risk model, shared risk, shared savings models like an accountable care organization. Because if you can keep patients out of the emergency room in a capitated or partially capitated plan, then that means that you share savings at the end of the year. The physician practice and the higher insurance third-party payer share savings at the end of the year. If it's a fee-for-service basis, the fee comes directly to, the reimbursement fee comes directly to that physician practice from the third-party payer, but the client user, the patient user, doesn't have to exchange money.
So, I'm sorry, but so you get a client, they're interested in this. I'm going to bring it way down to very minute.
Sure.
You spend $30,000, I think you said, to build your first system, right? And then your revenue stream from them, they pay you per patient, right?
Yes, correct.
And then who pays the doctors?
And then, well, it depends. So right now, there are a list of telemedicine services that are reimbursable by insurance right now. But what it would be is that the clinicians, so for example, let's say your practice right now has a 24-hour nursing hotline or something like that. So the way that they work out how they do the shifting and how they pay for those shifts is dependent on that health service delivery organization. So I'm not sure if that answers your question.
A little bit, but it
Sort
seems
of.
like it's going to
Okay.
depend on what kind of organization it is.
Definitely.
Absolutely,
Okay.
and their physician contracts, how they employ their physicians makes a difference.
Exactly.
So question.
Yes, sir.
So my company uses Teledoc right now. So I think, so I'd be interested to see your thoughts on this, but if I'm understanding this correctly, it's sort of going to what you were saying. So we use Teledoc, it actually comes through our health provider, right? What you're saying is you're actually you're not going to Aon or some of these big providers, you're actually going to the physician's office. And so you're trying to extrapolate money from the physician's offices versus the, is that correct?
That's
Correct.
correct.
Okay. And your pitch to them is going to be what? Because obviously they're pretty tight on margins. So your pitch to the physician's office is, a lot of them don't like spending money. So
Absolutely. The pitch is that there's downstream revenue in preventive care for sure. The shared savings, especially as more and more patients transition from fee-for-service plans to shared or capitated, partially capitated, or shared savings and shared risk models. This is, CMS is switching to this, and half of all, Center for Medicare Medicaid Services, half of all of their plans are going to be value-based, shared savings, shared risk models by 2019.
So services like this will help in terms of the bigger bang for their buck, meaning that if they have a capitated payment or patient and they're getting, I'm taking this off the top of my head, $200 a month for that patient, they have that $200 to work with in order to provide services for their patients. And the idea is that they want to be able to provide this preventative and primary care to their patients before it becomes more of an emergency acute situation, which costs them more money down the road. In addition to that, going back to the example that patients, if they're not able to get access to their primary care doctor or they need to get in and go see somebody quickly, they're starting to go to some of these retail medicine clinics, Walgreens or urgent care, which is then in turn taking revenue and business away from their primary care doctor's office.
So, I don't know if you're done. So the question I have is, I buy into the premise of telemedicine. I understand the convenience, the feasibility, et cetera, but I still struggle with the when question because I think this was valid 5 years ago. It might be valid 5 years from now. Why now?
That's an excellent question. Why us? Why now? The reason why now is because of recent changes. I know that PPACA, the Affordable Care Act, was passed in 2010. However, a lot of the changes to policy are finally coming to fruition, specifically in changes with the third-party payer system, shared savings, shared risk models, and...
No, I think that's a great point. And I think also what's happening now is that, as Amy mentioned before, there is a little bit more of a push in this direction. And all of a sudden, we're starting to see telemedicine take up in a much faster manner and in different avenues as well. And so when we look at those projections, we know that it's about to spike. And as we mentioned before, a relatively small number of patients are actually using or even being offered telemedicine services. So there's a lot of room for growth. We know someone's going to get there, and we want to be the first ones to do so.
Thank you.
Are there going to be extra costs on encryption for all this data zipping all over the place that you're talking about? I mean, because they're getting the credit cards pretty easy. There's a lot of data you're talking about.
That's true. We do not intend to be a data storage service. We'll be a throughput and integrate into the practice's existing security system. It will be HIPAA compliant and certified, which will cost us money, but we factored that into our initial setup cost, our initial build for each individual practice, depending on its size.
In your revenue assumptions, are you assuming that every patient is coming in more than once a year? Because I guess the $125 per user sounds kind of high based on reimbursement rates.
Sure. So they would probably come in as many times as they needed to. It would just be the unique patient identifier. They would have access, and then we would track it in a database, and the physician clinic would read it.
For the patient that comes once a year, I mean,
Sure.
a reimbursement rate on a general physician appointment, the doctor's probably not making very much money off
Sure.
of that.
No,
right?
that's a very good point. And I think what's interesting is that when we talk about that sort of that ideal 15% penetration model, where we want to be able to engage 15% of our HSDO client patients, that is coming from the patients that are going to be using those services on a more regular basis. So while we're not necessarily talking about that we want 15% of the patients that are only coming in once a year, we're looking at the broad spectrum and factoring in that wide continuum and broad spectrum of the number of patients that come in 7 times a year versus the number of patients that might come in 1 time a year versus the number of patients that are showing up in the ER as opposed to coming in. Exactly.
So can you clarify a bit about the technology?
Yes, sir.
So I understand the concept that you're approaching, but why can't I use my FaceTime client and a web browser and do the same thing that you're doing? So where is the technology advantage in your solution?
The technology advantage is particularly around HIPAA compliance. The reason that you wouldn't be able to just do a FaceTime with your doctor is that there are all these other components that go into it. Not only is it around HIPAA compliance, but it's also around whether or not that physician is able to use that type of service under their practice guidelines to interact with a patient. So, and does that answer your question? Okay.
So I'll dive in and
Okay.
say
You're
that
talking about regulatory versus technology.
Yes, so the regulatory components are driving some of the technological requirements and the technology specifically. So the difference key is that the physician will have the electronic health record and the patient's longitudinal history available at the same time. I mean, you could use FaceTime client, but it's not secure, it's not recordable, it's not drag and speak translatable, and it doesn't integrate into the electronic health record that physician practice is already using. We're talking about seamless integration.
Thank you.
Thank you.